On the other hand, if that child exhales, okay, they're exhaling into the open atmosphere. The more air they exhale, the lower the pressure is within that airway. And the airway has a greater tendency, therefore, to collapse because there's no force, internal force, that's stinting the airway open. So children who have asthma, that bronchospasm, affects expiration more than inspiration. In other words, their airways are more prone to collapse during expiration than inspiration. So initially, at least, they have more difficulty with moving air out. When you listen initially to a child who's got mild asthma, their lungs sound like this. Okay, you hear a whistling sound during expiration as air is rushing through a narrow passageway. And in addition, going along with that, there's a prolonged expiratory phase. It takes longer to move that air out. Now, as the bronchospasm continues to progress, it begins to impact inspiration as well. So that child, in order to force air out initially, they'll start using those accessory muscles of expiration. So a child who comes in with mild asthma, if their hospital gown is open to the front, you'll see that with each breath, they're contracting their abdominal muscles. And it's something that's very, very visible. It'll be noted on the initial history and physical exam. Now, if you treat that child with bronchodilators and they start to breathe more comfortably, they'll stop using those accessory muscles of expiration. If they don't respond to the medication and their condition continues to progress, then you'll notice that they'll begin to use accessory muscles of inspiration as well. And with each breath, you'll see flaring of the sternocleidomastoid, as now they're struggling not only to push air out, but to pull it in. Okay? Sometimes their wheezing initially increases. It goes from simply being expiratory wheezing to both inspiratory and expiratory. And if their condition continues to progress, the wheezing stops altogether. Why? Because they're not moving air. So that, instead of being a good sign, can be a bad sign if they stop wheezing.
Whenever there's issues within croup,
right?
Is that the same principle? Like, does it still start with expiration being the more of the issue?
You know, with croup, that's kind of a different thing altogether. The airway can completely close off.
Right.
And instead of wheezing, they have a condition called inspiratory stridor.
Right.
And many times it progresses real fast. So it's not as slowly progressive sometimes as asthma is.
Yeah.
And so that person can come in with they call it inspiratory stridor. It's a little bit lower pitched sound. It's a little bit different though.
Okay.
Yes.
I know sometimes they put children with asthma on prednisone. What does prednisone do?
It's an anti-inflammatory. Okay. In other words, when you treat asthma, there's two components to the treatment. You have to treat the bronchospasm, but if you treat the bronchospasm without treating the inflammation, then the child's not going to recover. It used to be, we didn't know that. It used to be that we just thought that you treated the bronchospasm. So a child came in, you put them on some bronchodilators, they improved and sent them home. Well, 6 hours later, they'd be right back. Because with the initiation of that asthma attack, there's the release of inflammatory mediators that cause swelling of the airway. So it's not just smooth muscle contraction. Okay, there's also an inflammatory component that has to be addressed. And if you don't, they're not going to get better. So you have to treat them with an anti-inflammatory as well. Okay, so let's look. At rest, intrapleural pressure. When I say intrapleural, I mean the pressure inside the pleural cavity is always negative with respect to intrapulmonary pressure. So what I'm saying is that the pressure in that pleural space is about 4 millimeters less than the pressure inside the lungs, the intrapulmonary pressure. And at rest, I said the intrapulmonary pressure is the same as atmospheric pressure, because the lungs are open to the atmosphere. So at sea level here, atmospheric pressure is 760. So that would be the intrapulmonary, and another term for this is alveolar pressure, 760 millimeters mercury. At the same time, at rest, intrapleural pressure, the pressure outside the lungs within the pleural cavity, is about 4 millimeters less, about 756 millimeters mercury. Okay? So we could say that intrapleural pressure is negative with respect to alveolar pressure, okay, by about 4 millimeters. And that negative pressure creates a type of suction that keeps the lungs expanded. In fact, so much so that if you were to disrupt that negative pressure inside the pleura, the lungs would collapse. Why? Because the lung tissue has a tremendous number of elastic fibers that serve as little rubber bands. Okay? So the lungs would tend to recoil if it weren't, God bless, if it weren't for that external negative pressure keeping the lungs open. Okay? Now, what this shows, now let's draw in the layers of the pleural sac here. This would be the visceral pleura, and it's attached to the external surface of the lung. Okay? At the hilum, okay, it turns back on itself like this and creates the parietal pleura. Notice that the parietal pleura is attached to the superior surface of the diaphragm. Okay. It would also be attached to the inner surface of the rib cage here. Okay. Let's draw our pressures. We said 760 at rest within the lungs, pulmonary, 756 inside this pleural space, so it's negative with respect to the lungs. We said that if you disrupt that negative pressure in the pleural space, the lungs are going to collapse. What do we call that condition, where the lungs collapse due to loss of negative pressure?
Pneumothorax.
Pneumothorax. Yeah, so if you're walking in the water this evening, okay, and someone comes with a knife and jugs you, okay, that knife goes between the ribs. What does it do? It disrupts the parietal pleura and allows air from the atmosphere to enter into the pleural space. Now you lose that negative pressure, so the lungs will collapse, or at least that right lung will collapse. You know that the two pleural cavities are separate and distinct. They're not connected. All right, so let's go back to our standard situation here. If I do this, if I take a deep breath, okay? No, let's say a standard breath, not a deep breath, a standard breath. I'm going to move the diaphragm down. Like this, okay? Now, when I move the diaphragm down, the parietal pleura comes with it. So in moving the diaphragm down, I've expanded the intrapleural space or volume. So what would happen to the intrapleural pressure? Would it remain at 756?
No.
No, it would drop down perhaps to 754. So when the intrapleural space expands, the intrapleural pressure drops. It goes from 756 to 754, so there is a greater negative pressure. We can think of that negative pressure as acting upon the lung, creating a greater suction type effect, which in turn will cause expansion of the lungs. Okay? So as this negative pressure increases, okay, it goes from 4 to 6, then that acts upon the lungs to cause them expansion. It's going to pull on this visceral pleura, which is tethered to the lungs. So the visceral pleura can pull outward like this, and with that we have expansion of the lungs. Of course, when the lung expands, what happens to the intrapulmonary or alveolar pressure?
It decreases.
Drops down to, let's say, 758 instead of 760. And then, as that happens, then we create a pressure gradient such that air is going to flow into the lungs as a result. Does that make sense to everyone? And this happens within fractions of a second. We take a breath in, and the pleural pressure falls. That in turn results in a drop in intrapulmonary pressure, which, God bless, creates a pressure gradient. So what do you have to do when you're sneezing? Were you the one that told me? No, you didn't say. Okay.
No, it was her that said it.
What was?
It was looked up.
I know if you want to sneeze, you look at the light. If you want to stop from sneezing, what do you do?
Oh, say mustard.
Say mustard. Okay.
It works. It's something about like the whenever you say that word.
Okay. Now, by the way, so the opposite happens when you exhale. When you exhale, the diaphragm moves up, so intrapleural pressure increases. There's less negative pressure to expand the lungs, so the lungs become compressed. Intrapulmonary pressure increases, and that drives air out. So breathing, ventilation, is simply a matter of mechanics. I'm going to throw something else out there. The expansion of the lungs depends on what's called transmural pressure. Transmural pressure is the difference in pressure between inside the lungs and outside. We can say alveolar pressure, or alveolar pressure versus pleural pressure. So, if at rest, the alveolar pressure is 760, and the intrapleural pressure is 756. We subtract the two, that means there is 4 millimeters of transmural pressure that tends to expand the lungs, that keeps the lungs expanded as opposed to collapse. When we take that breath in, what happens to intrapleural pressure? It falls. So now instead of 760 minus 756, we have 760 minus 754. The transmural pressure increases to 6. So there's a greater pressure that tends to cause greater expansion of the lungs, because the expansion of the lungs depends upon that transmural pressure. If someone develops a pneumothorax and this intrapleural pressure is 760, 760 minus 760 is 0. There is no transmural pressure tending to expand the lungs, so the lungs collapse. So you can think of the expansion of the lungs in terms of that difference in pressure between inside and outside of the lungs. Okay. So what we've established then is that differences in pressure gradients, are one of the primary factors that drive airflow, very analogous to blood flow. What I show you on this particular slide is that there are 3 other factors that affect airflow and ease of ventilation: airway resistance, alveolar surface tension, and lung compliance. So we'll attack these one at a time. Airway resistance. in general, flow is equal to change in pressure, that's the pressure gradient between outside and inside, divided by resistance. In other words, the greater the airway resistance, the greater the denominator here, the less the airflow. When we talked about the cardiovascular system, we said that the major factor that determines vascular resistance is the diameter of the blood vessels. The smaller the diameter of the blood vessels, the more resistance to flow there is, the more friction created, okay, between the blood and the walls of the vessels. Well, the same thing occurs within airways. Resistance is mainly determined by airway diameter. As airways get smaller, there's greater resistance. As resistance increases, it impacts flow. Okay? So a child with asthma, as a result of bronchospasm, narrowing of the airways, their resistance goes up, that decreases airflow. So what they're going to try to do in an effort to maintain airflow is to increase the pressure gradient between atmosphere and the lungs. So they're going to try to expand the lungs more with inspiration, or compress the lungs more with expiration, okay, to compensate for the increased resistance. Okay? And the way they create that increased pressure gradient is by using accessory muscles. By the way, people who come in who struggle to breathe are very panicky. Hypoxemia, not getting enough oxygen, creates anxiety. So these children are very, very, very anxious. Okay. I'm going to